Please start.
Yeah. Dr. Jyoti is the master of ceremony today. Dr. Jyoti, I request you to kindly start the proceedings.
Yes, ma'am. A very good evening to esteemed office bearers, chairpersons, experts, and moderators. Today, we are here for this esteemed webinar. Learning is one journey that becomes richer when shared. With this thought, it gives me immense pleasure to welcome each one of you for today's webinar organized by Indian Fertility Society Special Interest Group on Female Genital Tract Tuberculosis in collaboration with IFS Haryana Chapter. As we gather here on National Doctors' Day, we honor the noble profession that stands at the forefront of healing and scientific advancement. It is my proud privilege to invite a stalwart in the field of reproductive medicine, a revered teacher, mentor, and guiding force for countless patients across the country, Dr. Sudha Prasad, ma'am, for the mentor's address.
Thank you so much,
Dr. Prasad,
Jyoti.
ma'am. Yes, ma'am.
It's okay. I think we should not waste time on this.
I think everybody knows, ma'am.
Dr.
Ma'am,
Sudha
we are
Prasad.
eager to hear you.
Really?
We can remove this. Okay.
इसके डब्बे के पीछे पड़ी थी मुझे दिखी
I kindly request all the attendees to mute themselves and all the questions can be addressed in the chat box. Karan, please share.
Hi, ma'am. Dr. Sudha, ma'am,
Dr.
we are
Sudham's slides.
Have you finished, Jyoti?
yes, ma'am. Yes, you can.
Thank you so much, Jyoti. I congratulate Rashmi and your team to making it so wonderful webinar. Good evening to all of you and welcome you all in this unique kind of SIG subject on tuberculosis, genital tuberculosis in females. If you see the data, according to the Global Tuberculosis Portal 2025 by the WHO, it has shown that globally 10.7 million people are harboring TB in 2024. That means every 131 incident cases are there per 100,000 population. And out of this, 34% are only in the Southeast Asia. And maximum percentage, like 25% are in India. So you can see the magnitude still how much is there of tuberculosis. And if we see that that how much is the latent tuberculosis? So latent tuberculosis in our country in 2020, it has been seen that it is a notifiable disease. So it's very difficult to see that, but whatever notification comes, that has been taken by the government, and it has shown that nearly 40% of the population are harboring latent tuberculosis. So one can think of that how much is this, that latent tuberculosis is still present in our country. Question comes that what is latent tuberculosis? It is the immune response to stimulation by the Mycobacterium tuberculosis antigen in the absence of clinically active tuberculosis. So prevalence has been seen nearly 19.7% in females. So these 19.7, 20% females are in the young age group, and that is the problem we are facing, that how to make them pregnant, because endometrium is eaten up or the fallopian tube is eaten up. So we have to really find out the reason and solution of this problem. And if you see the data of the Delhi only, I was shocked after going through this data. It is 61.2% people in Delhi only are harboring tuberculosis. So we can't say that now it is decrease of, it is in decrease, of course, but still it is as high as possible. There are the many ways to do the test or the investigation. I did 2 projects. I just want to tell you about my own projects, that we have screened 700 cases at Maulana Azad Medical College. And after that, we have found out 400 cases were recruited who had a doubt of the tuberculosis, latent tuberculosis. And we did all tests like histopathology, AFB culture, DNA PCR, RT-PCR. And finally, we found out that there are the patients who have gone through the RT-PCR are the best one, because we have taken out that nearly 11 patients out of these these total number of patients were positive with the RT-PCR, whereas only 4 to something like few number, very minimal number were positive by other methodology. When the gene expert came, so as a government hospital, we got the gene expert to do the test about it. And out of 176 gene expert patients, we have done, and we found that only 11.1% were sensitivity, whereas 100% were specificity. So this gene expert is having a very low sensitive test. Now we have to really find out the methodology, the investigation, what exactly has to be done for these patients, because these are the very, very challenging cases where the infertility is there. So due to the possibacilli, the problem is there that which test has to be done, which can have the proper. I feel that in this webinar, something or other will come out, because there are so many experts are there that they will just find out, and just they will convince you that this is the test which is very much important when you start investigating the genital tuberculosis, especially the latent tuberculosis. So I wish you all for the great success of this webinar. Thank you so much for giving me time. Thank you, Rashmi.
Thank you so much, ma'am.
Thank you very much, ma'am, for your inspiring words, your vast experience, and thoughtful guidance and unwavering dedication for the advancing reproductive medicine continues to motivate us all. Dr. Professor Neena Malhotra ma'am has not been able to join us, so we will move forward with the Secretary General's address. It is now my proud privilege to invite one of the most dynamic leaders of Indian Fertility Society, Dr. Shweta Gupta, Secretary General, Indian Fertility Society, to kindly address the gathering. Her visionary leadership continues to elevate the standards of our society and inspire excellence.
Thank you, SIG Tuberculosis. So on behalf of Indian Fertility Society, I welcome you all. And this specific SIG is, I think, where we Indians should take the lead, because most of the data, most of the studies, and also very carefully selected. I think the mentor herself, ma'am, has a huge experience of working in a government premium institute. So we thought, she is the best person to guide all of us. And along with ma'am, Sudha ma'am, we have Rashmi, who has done a lot of work. We have 2 very enthusiastic co-conveners, Nitasha as well as Nisha. So I'm sure this group is going to really do well. And I think we have more expectations from this, our Indian special interest group, than other groups where most of the time we are looking into the Western literature. So I was just before the webinar start, I was just talking to madam. I thought maybe in South Delhi, we are getting less patients. But, on a deeper thoughts, is it because we are detecting less, because we are, whether we are missing as an unexplained or poor ovarian reserve, and then we are not able to treat? So I remember when we were in Harding or, medical colleges, we used to look very closely that every patient, infectious or whatever, the tuberculosis, that was the one of the main important tests. And nowadays, I think it is getting less and less, or whether it's because of the notification, which ma'am has said, because the people are not notifying because they are not able to detect. So we have to really give a deeper thought, as ma'am has just said, that the figures are still there. There is a quite a high incidence of tuberculosis. Maybe there is a little disparity. In some sections there is more prevalence, the other sections less. And I'm sure this particular webinar is going to be little brainstorming. And I also saw the program where has we have other past presidents, including Sonia Madam, Gauri Madam. So I'm sure it's going to be really very, I think it will give us a lot of insight onto this much awaited topic. So over to Rashmi. Rashmi, all yours.
Thank you so much, Dr. Shweta. Thank you so much.
Every successful academic initiative is driven by passionate individuals who transform ideas into meaningful actions. It is now my privilege to invite the driving force behind this webinar, the convener of the IFS SIG on female genital tract tuberculosis, Dr. Rashmi Sharma. Ma'am has been instrumental in conceptualizing the special interest group and in bringing together the experts from across the country and share their vision on improving awareness, diagnosis, and management of female genital TB. May I request Dr. Rashmi Sharma ma'am to deliver the welcome address. The podium
Thank you
is
so much, Dr. Jyoti. So good evening, everyone. On behalf of IFS and SIG team, I warmly welcome all the esteemed faculty members, all the seniors, Dr. Sudha ma'am, Dr. Sonia ma'am, Dr. Gauri ma'am, moderators, panelists, and participants for today's SATYAM webinar. So that's the series of the name of the series that we have given to the SIG-TB program, which is SATYAM. SATYAM stands for Strategic Awareness for Genital Tuberculosis, yielding accurate diagnosis and management. Since we all know, despite advancement in diagnostics and treatment, genital TB remains one of the most controversial topics in the infertility practice. Everybody does different tests. We still see menstrual blood for TB PCR. We still see, treatment being started for just being Montaux positive or just being, quantiferon gold positive. So this is one area which needs lot of discussions, lot of webinars, lot of awareness among the Indian specialists, so that we can bridge this gap through education, research, and collaborative discussion. So in the SIG-TB activities, this is what we plan to do. We plan to do lots and lots of awareness program for correct diagnostic methods, correct investigations, and correct treatment. Also, I would like to share that SIG-TB is planning to take a nationwide cross-sectional survey to understand what are the current practices which is being followed by all the specialists or the gynecologists for managing and diagnosing the genital TB. And for that, I sincerely look forward to the enthusiastic participation and support of all our colleagues in this important initiative. Today, we are also releasing the IFS newsletter on TB today with lots of encouragement from my dear friend, IFS editor, Dr. Leena Vadva. I'll show you I'll share the newsletter with all of you today, and it will be widely publicized in all the forums. And it has a beautiful review article with all the latest advancement and a beautiful case report by Dr. Nisha Patnagar. I really thank the Infertility Society and our chapter organizers, our expert faculty, and every participant who has taken out time to join us today. And I wish you all a very engaging, interactive, and academically enriching session. Thank you. Thank you.
Thank you, ma'am. It is now my privilege to introduce the esteemed chairpersons for the session regarding making the diagnosis from clinical suspicion to confirmed disease. We are truly honored to have two stalwarts of reproductive medicine and infertility with us today. Dr. Sudha Prasad ma'am, our first chairperson, is an iconic name in the field of obstetrics and gynecology, and reproductive medicine, a highly respected clinician, academician, mentor, and teacher. She has inspired generations of fertility specialists through her exceptional contribution to patient care, research, and education. As the mentor of IFS SIG on female genital TB, her vision and guidance continue to shape this important initiative. Ma'am, it is a privilege and honor to have you chair this session. Joining ma'am is Dr. Gauri Devi, an esteemed infertility specialist, eminent academician whose vast clinical expertise and thoughtful insights have earned her immense respect across the fraternity. Her dedication to advancing evidence-based fertility care and her commitment to achieving this made a highly valued leader in reproductive medicine. I think, ma'am, Dr. Gauri has not yet joined, so we can.
Ma'am has joined. Ma'am is joined. Ma'am is muted. Ma'am is here. Hi, ma'am.
Yes, ma'am.
Yeah.
On behalf of Indian Fertility Society and IFS Chapter, I extend a very warm welcome to both our esteemed chairpersons. We are privileged to have your wisdom and guidance. And now I request both our respected chairpersons to kindly preside over this session.
Thank you.
Thank you, Dr. Jyoti, for a nice introduction. And Dr. Rashmi had been already just introduced by Jyoti because these introductions are taking more time.
Yes,
So
ma'am.
let us
I
get
think we should start.
talking on to the subject. And I'm sure Rashmi is going to give us some insights and to the diagnosis of, or at least how we make an attempt at the diagnosis. Now, before starting, let me wish all the doctors a very happy Doctors' Day. Rashmi,
Thank
your
you so much,
stage.
ma'am.
Yes.
Thank you so much. Can you see the screen, ma'am? Is my screen?
Yes, enlarge it to the
Yes, ma'am.
slideshow.
Yes. Okay. Yeah. So I'll be fast so that we can cover a lot of ground. So topic is female genital tuberculosis. How do you make the diagnosis from clinical suspicion to confirmed disease? So I will not be pondering much on the treatment, but on the diagnosis. And I guess diagnosis.
Slideshow, Rashmi?
Acha, ma'am. Okay. Yes.
Yeah.
Is
Thank
it
you.
okay now?
Yes.
Yeah.
Yes, ma'am. So I'll be covering from diagnosis, mostly the diagnosis. The treatment part, I wouldn't be covering much because that is, I think we all know, it's the diagnosis which really troubles us. We know it can be an overt tuberculosis where the signs are very obvious, and it can be a very latent tuberculosis, which is very difficult to diagnose. So, but why TB matters? As Dr. Sudha had already told, this is the latest WHO 2025 report. It says still now in 2024, we have about 10.8 million new TB cases, and India's share is about 26% of the global TB burden, which is still very high. Though encouraging news is that India has shown the sharpest decline in the TB cases in the last year, which is about to the tune of 25%. Our cases used to be about 230 per million, which is now at about 130 per million. But we are still nowhere near eliminating TB altogether. So we still have a lot of ground to cover. Among the tuberculosis, it is about 66 to 25% female genital tuberculosis is there among the patients who are coming with infertility. And the key context is that about 10 to 12% of women with FGTB, that is female genital TB, will be completely asymptomatic. So they will be an asymptomatic patient, still will be suffering from genital TB. So a high index of suspicion is mandatory. So just a little bit of background, 90 to 95% of TB is due to Mycobacterium tuberculosis. We all know that. 5 to 10% may be due to Mycobacterium bovis from unpasteurized infected milk. It is rarely primary. That means through direct inoculation, hardly ever we will see a case which is through sexually transmitted disease. Mostly it is due to secondary TB, due to TB somewhere else in the body. So it is usually hematogenous spread. Mostly there is a primary focus in the lungs or in lymph nodes, and it spreads to the genital organ either through blood or through lymphatics. Directly, sometimes maybe through GIT, mesenteric lymph node and peritoneum, they can be a direct involvement from outside of the genital organs. So because it is mostly hematogenous, and the tubal epithelium is very thin and very vascular, that is why the most commonly affected organ is the tubal endosalpingitis. So the first thing would be affected would be tubal endosalpingitis. That is the first involvement. Rarely it can be exosalpingitis, as I said, direct involvement through a GIT or mesenteric lymph node TB. So the organs involved in female genital TB is almost 100% of the cases, fallopian tubes would be involved. In about 70%, endometrium or uterus would also be involved. But even the ovaries are involved in about 30% of the cases, and that can lead to decreased AMH and decreased AFC. In 10% of the cases with direct inoculation, there can be a cervical involvement, which can mimic cervical cancer. Rarely, they can be a vaginal or vulval tuberculosis as well, which is about 1%. Latent TB is a condition where the individual has Mycobacterium tuberculosis but does not currently have the active disease. So that means so many of us are harboring TB bacteria, but our immunity is taking care of it, and we do not have active disease. Whenever our immunity will go down, the TB will be reactivated. That is what is latent TB. So what are the risk factors? Risk factor for reactivation, we all know, immunocompromised or HIV, there will be reactivation. If somebody is taking biological agents, if there are surgical manipulation like laparoscopy, stroscopy, HSD, we have all seen once in a while a case where due to HSD or due to laparoscopy or due to some sort of surgical manipulation, TB gets reactivated. High steroid levels, increased vascularity during ovarian stimulation itself during IVF can increase TB risk, and empirical use of steroids and immunotherapies, which is very common in patients with RIF and recurrent pregnancy losses, that too can increase the risk factor for reactivation. So we have to be aware about the latent tuberculosis as well. How do we diagnose? Diagnosis is difficult and delayed because the symptoms, they appear very late when the significant organ damage has already happened. So incidence of genital TB varies not only with the prevalence of TB in the community, but also with the physician's interest in searching for the disease. This is a very old statement in 1964, but I think this still holds true. If you do not know, your eyes will not see. So you have to be aware that TB can happen, and then only we can find it. So for diagnosis, you have to have a very high index of suspicion, thorough clinical examination, and appropriate investigation. If we are mindful of TB, then we can diagnose. So for the, for high risk factors, in which we have to be very careful that, we have to actually search TB, is if the patient gives family history of TB, because 20% of these patients will give family history of TB. 30 to 50% might have had some form of TB or ATD in their past history. So we have to ask past history of TB. We have to ask family history of TB. If the patient is coming from poor socioeconomic background, because the area in which they are living may not be well ventilated, and those are the areas where TB is very common. If there is drug use, if the patient is HIV positive, if there is a history of chronic chest symptoms, then we have to be aware that TB may happen. So always suspect if you have infertility for which no other obvious cause can be found. If you are dealing with chronic pelvic inflammatory disease which is refractory to standard antibiotic therapy, be aware that it may be TB. Or if you're dealing with an adnexal disease with ascites. Okay. What are the symptoms of genital TB? It's a chronic disease of low-grade symptomatology with very few specific complaints. That's why it is so difficult to diagnose. In the systemic, we all know they can be weight loss, they can be fatigue, they can be low-grade fever. Infertility is one of the very commonly presenting symptoms. In the initial part of genital TB, there will be menorrhagia. And then when the TB has actually damaged the endometrium, there will be oligo or hypomenorrhea, sometimes even amenorrhea. There may be abdominal pain in about 50% of the cases. There may be dyspareunia. There may be dysmenorrhea. So these are all vague symptoms, and that is why the diagnosis becomes difficult. If we look at the physical signs in genital TB, it may be completely normal. There may be no signs. There may be temperature. There may be an abdominal mass. There may be a pelvic or adnexal mass. There may be a doughy feel of the abdomen, abdominal, pelvic or adnexal tenderness you can find. Sometimes you may find ascites, and sometimes there may be excessive vaginal discharge. Rarely there can be an ulcer in vulva, vagina or cervix, which is very rare. So just be mindful of the abdominal examination and tenderness, pelvic tenderness, adnexal tenderness, doughy feel of the abdomen. We should think about TB also in our scenario. and they may be an enlarged uterus with pyometra. So there are some non-specific investigation which sometimes can hint, like in the TLC examination, if you find a tendency towards lymphocytosis, it can be, a sign towards TB, raised ESR. Maybe their chest X-ray may show a picture of active or healed lesion. Sometimes you find microscopic hematuria or abacteriuric pyuria, which can suggest urinary tract involvement. These can be, just little hints that, should think about TB as well. Then there are specific tests for genital tuberculosis, and I will discuss these in detail one by one. Ultrasound, HSD, imaging methods, then we have endoscopy, histopathology, AFP staining, culture methods, immunological test, and molecular test. And I think we should know these tests in detail so that we can choose the best and diagnose it in the best possible manner. So we have to be mindful that no single diagnostic test currently satisfies all the demands of a rapid, affordable, and easy test. So there is no single test. We will have to go with comprehensive testing. In the ultrasound, you can find so many evidences like loculated ascites, tubo-ovarian masses, cogwheel appearance of the tubes. They can be tubo-ovarian complexes. So these are the various signs you can find: thickened endometrium, omentum, thickened peritoneum, endometrial involvement, which can alert the clinician to suspect genital TB. Then in the HSD, number one, should never be done if you are suspecting TB, because HSD can lead to exacerbation of disease, and I have seen such exacerbations. It is definitely contraindicated if you are seeing an adnexal mass, then do not do HSD. But if somehow HSD has already been done, then you can find rigid pipe stem tubes, a clubbed ampulla with retort-shaped hydrosalpinges. I'll just show you some of the pictures. So this is a flask-shaped fallopian tube. This might indicate TB. There can be a cotton wool plug appearance. They can be varying degrees of hydrosalpinges. They can be bilateral masses even after ATT. They can be tufted appearances near the ampullary region. They can be pipe stem appearances. They can be beaded appearances, eroded looking uterine cavity. So there are many signs which has been described in HSD. Intravasation is also one of the very important signs of tuberculosis. You find so much of intravasation in cases of TB. Lymph node calcification sometimes you find, and this is like severe Asherman syndrome. So lots of features that you can think about TB in such type of HSD scenarios. Then there are endoscopic features suggestive of TB. Suppose you're doing laparoscopy, you can find tubercles on the peritoneum or ovary. You can find TO masses. You can find caseous nodules. You can find encysted ascites, varying degrees of pelvic adhesions. And there are lots of signs which have been described so beautifully by Dr. J.B. Sharma. Sharma's blue python sign, kissing fallopian tube sign, hanging gallbladder sign, parachute sign. So this is a blue python sign. This is a paper, a case report by Dr. J.B. Sharma. This is a kissing ovaries sign. These are the caseous nodules that we can see, different types of hydrosalpinges. And these are the caseous nodules that you can see here. Ascites, straw-colored ascites, tubercles. Again, you can see multiple tubercles here. Adhesions, varying degrees of adhesion. So these are all signs. These are typical caseating nodule. I think we have all seen these, and I think we all recognize these. So these are the various findings. If you see a laparoscopy like this is straight away tuberculosis, and just based on this, you can start ATT. I'll come to the treatment part later, but yes. And there are some hysteroscopic findings. Hysteroscopy should always be combined with laparoscopy if you are doing laparoscopy for fertility purpose. And in the hysteroscopy, you can find a very pale, atrophic, avascular endometrium. Sometimes you can even see yellowish deposits, which are tubercles. You can see caseous nodules. You can see chronic endometritis pattern. You can see varying degrees of adhesions, even severe Asherman. Sometimes it's a distorted truncan cavity, unobliterated cornual ostia. So these are the few pictures of various hysteroscopy pictures in tuberculosis. And then, of course, we should be trying to make a histopathological diagnosis. And when you take an endometrial biopsy or biopsy from somewhere, wherever you are suspecting TB, in histology, we typically find a caseous granulomatous lesion. So there is a caseation, central caseation surrounded by giant epithelial cells. Such lesions, they are very suggestive of TB, but they're not diagnostic because they can appear in fungal infections also and sometimes in sarcoidosis also. But this is the typical histopathology appearance of tuberculosis caseous lesion. And then in the microscopic diagnosis, the test that comes is AFP smear. I think we all know that. It's a very simple test, very rapid, but the only problem is that the sensitivity is very low because you will require at least 10 raised to the power 4 to 10 raised to the power 6 bacilli per ml in the specimen to give a positive result. So by that time, the patient is already extremely sick. Right. In the AFP smear, the another addition is fluorescent staining or lead microscopy. So it's a quick diagnosis, but very, very poor sensitivity. So even by addition of fluorescence lead microscopy, the sensitivity rate does not improve. This is in cases of chest tuberculosis. By the time AFP smear detects TB, the patient is already too weak to work. Patient is already very sick. So you cannot depend on AFP smear for early diagnosis of the disease. So then comes the culture, which is the gold standard. Its sensitivity is higher than the AFP smear. How much can it detect? It can detect up to 10 to 100 bacilli per ml. There are two types of culture. One is the solid Lowenstein-Jensen medium, and then there are new methods. So now no longer we send Lowenstein-Jensen medium because it takes 6-week reporting time, and we send newer methods. What are the newer culture methods? One is BACTEC 460. It was based on the radiometric method, which has been banned because of the radiation hazard. Another is BACTEC MJIT 960, which is Mycobacterium growth inhibitor 2, which is based on the fluorometric methods. This culture method detects bacterial O2 consumption. It is fully automated, rapid, and sensitive. Another is BACTI-ALERT, which is based on the colorimetric method that detects bacterial CO2. This is also fully automated, rapid, and quick results. Another is BAC-ALERT 3D, which is also automated liquid culture system. But any of these culture methods also, they do not reduce the turnaround time below 12 days, nor they improve the rate of positivity beyond the limit. So the positivity rate is about 10 to 100 bacilli per ml, and the reporting time is minimum 12 to 14 days. So if we have to send, don't send a normal LJ medium culture, we always have to send BACTEC. Then now comes the nucleic acid amplification test. I think there's lots of confusion about it. We know it's a very rapid procedure, about 3 to 4 hours, and it's a very high sensitivity, about 1 to 10 bacilli. But what are the advantages of doing a conventional TB PCR? It is very expensive. It requires specialist training and equipment. You need a really sterile room, otherwise there can be a lot of contamination. So training is very important, equipment is very important, and the place where it is being done should be very, very sterile. False positive rates are very high of the conventional TB PCR due to contamination from lab and while collecting the sample. Inability to detect a difference between viable and non-viable organism because it is detecting DNA of the bacteria. DNA is there even in the dead bacteria. So it cannot say whether it is live or dead. And therefore, the test can remain positive for longer periods in patients who are taking anti-TB medication or who have even completed TB treatment. So these are the biggest disadvantages. False negatives can also happen because of presence of PCR inhibitors, right? Not only because the DNA load was low, but also because there are cases where culture was positive and DNA PCR was negative. So this was a study, beautiful study from Indore, I guess, in 2014, in which PCR negative sample were positive by culture method. So only PCR you cannot depend for TB diagnosis. This was a paper by Dr. Nalini. And here, 7 culture positive cases were PCR negative. So even if it's culture positive, PCR can be negative because there are PCR inhibitors in the sample. Then messenger RNA testing, because it can detect live organism. The major drawback is it needs to be transported in ice to laboratory within 2 hours to prevent degradation of RNA because the average half-life of bacterial messenger RNA is 3 minutes. So it's practically actually not possible to do messenger RNA testing. Now comes the best investigation now, which is Gene Expert, which was endorsed first by WHO in 2010. It is a cartridge-based semi-automated DNA PCR testing. That means it has removed specialist training. It has removed that sterile environment compliance. It's a machine-based and DNA PCR. Plus also simultaneously, this test is detecting majority of the mutation which confer the rifampicin resistance in the bacteria. The entire process is carried out in a closed automated system except for addition of the specimen into the cartridge, thus reducing contamination. So there's no contamination. You just have to add the specimen into the machine, and machine in 2 hours will give you the report, DNA report. So this is the machine of TB expert, wherein you take the sample, liquefy, and just put in, with a medium, and just put the cartridge in the machine. The machine is doing the whole procedure, and within 1 hour 45 minutes, it tells you whether it can see the TB DNA or not, and whether resistance is there with rifampicin or not. So that's a fantastic upgrade. It is WHO endorsed. This is the standardized nucleic acid amplification test. Rapid diagnosis, it detects rifampicin resistant and reduced sensitivity in possibility bacillary disease is there, because limitation is there. It can detect just 1 to 10 bacilli. So one very important message here is that wherever feasible, endometrial samples should undergo WHO endorsed testing like TrueNet MTB or MTB Plus or Gene Expert MTB. We should no longer be sending the conventional PCR, right? Because those are not standardized. And just based on conventional PCR, ATT should never be started. This is a very important message that I would like to convey to the delegates who are attending the webinar. Now coming to the immunological tests. Immunological, wherein we are trying to detect whether the patient has anyways kabhi exposed hua hai TB se ya nahi. So there are 2 types of immunological tests. One is Montuxed, which we all know, which is a tuberculin sensitivity test, which is an in vivo test. The second is interferon gamma release assay, which is the IGRA or in vitro. And in vitro IGRA tests are basically 2 types, Q-Gold and TB spot. So coming to IGRA, what we do in interferon gamma release assay, we take the blood from the person, and this is incubated with some synthetic peptides. And these synthetic peptides, which are ESET6 and CFP10, they are 2 proteins which are present in Mycobacterium tuberculosis. So the blood taken from the patient is mixed with these 2 peptides. The lymphocytes of the patient, if they have been exposed to these peptides before, they will release gamma interferon in response, and then we detect that gamma interferon. That tells us that the patient immune system recognizes TB and has sometime been exposed to TB. And these proteins, they're absent in BCG strains, and they're also not present in most of the non-tubercular mycobacteria. So IGRA will not come positive even if the patient has been vaccinated with BCG, and it will not come positive in non-tuberculous mycobacteria. It has definitely higher specificity than Montux, because Montux will be positive even in BCG vaccinated patients. It requires a single visit only to conduct the test. The result of IGRA can be available in just 24 hours. It does not boost responses measured by the subsequent test. So like you cannot do a repeat Montux, but you can always do a repeat Q-Gold. Prior BCG vaccination does not cause a false positive IGRA result. Results are objective and they're not subjective, like we are not measuring the swelling as in cases of Montux test. So positive test of IGRA or quantiferon fold, it confirms latent tuberculosis infection. It does not confirm genital involvement. So that's very important. It does not confirm that patient has an active disease. It just confirms that patient might be having latent tuberculosis infection. So in infertility workup, IGRA or TST is just a screening. Positive result only tells us that yes, this patient may need further sampling, further endometrial sampling. It is not an indication for treatment. So if let's say you are seeing a patient of unexplained infertility and only IGRA is positive, this indicates exposure to MTB. It does not indicate genital TB in the absence of tissue diagnosis. In fact, in endemic countries, latent TB is not treated because of a high possibility of repeated exposures. So quantiferon gold is taken for treatment in countries like US, Germany, etc., where latent TB is not so common, but not in the Asian subcontinent where the latent TB is very common. Now, just coming to the ICMR standard treatment chart. When do we treat? So, definite female genital TB wherein you have to start ATT is if you find AFP positive, 100% patient is positive. If you find AFB culture positive, If you find gene expert or NAT positive, it is an indication to start ATT as per the ICMR. Or if you find histopathology and you find an epithelioid granuloma, these might be indication to start ATT. Then there are some probable cases wherein you would think of starting ATT, like if you have deep clinical suspicion and along with that on ultrasound you find tubo-ovarian masses, you are right to start ATT in those cases. Still, you would like to, confirm through the microbiological testing, but yeah, you might think. Then there is clinical suspicion plus you find laparoscopy finding or hysteroscopic findings, then you might think about starting ATT. When will you not start ATT? If there is no microbiological evidence, no histological evidence, no radiological evidence, no laparoscopic or hysteroscopic evidence. Very important thing is that menstrual blood must not be used for DNA, for NAT testing or for PCR testing. Number two, PCR alone, that is conventional PCR alone, is insufficient to diagnose female genital TB or initiate ATT. Still, we see patients where they have been started ATT just based on Montoux test, just based on menstrual blood PCR. Today only I saw a patient who has been tested for menstrual blood for PCR, which is not indicated. You have to take endometrium for testing. Yeah. And there is a change in the anti-tubercular therapy regimen, which I would like to draw attention by the NTEP program, National Tuberculosis Elimination Program. So basically, it is 6 months therapy, wherein 2 months of 4 drugs as usual that we used to give, and now 4 months we give 3 drugs, that is rifampicin, isoniazid, and ethambutol. So not 2. Earlier it was 2 drugs. Now it is 3 drugs in the later 4 months. And very, very important that any TB treatment that you are starting should be notified to the government via the Nikshay portal. It is a mandatory program. There is a Nikshay Poshan Yojana program also, wherein the patients get nutritional support of about 500 rupees. I think it has increased to about 1,000 rupees per month from the side of the government. And that is the reason why we have had almost 25% decline in the TB cases in the last year. So just to conclude, 10 very key practical recommendations. One is maintain a very high index of suspicion for TB. Then only you will be able to diagnose. Number 2, do not rely on a single diagnostic test. Send gene experts, send histopathology, send AFP smear, send AFP culture. And whenever feasible, endometrial sample should undergo WHO endorsed testing like TrueNet MTP or MTP Plus or Gene Expert MTP with rifampicin resistance testing together with mycobacterial culture and histopathological examination. तो यहाँ हमको कंजूस नहीं होना है, हमें सारे टेस्ट भेजने हैं because it has to be a corroborative diagnosis. Conventional PCR should not be routinely used as a standalone diagnostic test, nor should isolated PCR positivity prompt the anti-tubercular therapy. So do not start it just based on conventional PCR positive. Hysteroscopy and laparoscopy should be used judiciously to evaluate the disease extent, obtain tissue for diagnosis, assess the reproductive prognosis, treat the confirmed drug-sensitive FGTB according to the NTEP guidelines. Giving ATD more than 6 months is not justified. Counsel patients that microbiological cure does not necessarily restore fertility. So having a microbiological cure is different than having a fertility outcome. Always treat hydrosalpinx before embryo transfer and do not delay assisted reproductive treatment unnecessarily, and establish a multidisciplinary collaboration with pulmonologist, with microbiologist, etc. Thank you.
Thank you, ma'am.
Thank you so much, Rashmi.
Thank you, ma'am.
Giving us an elaborated insight for the tuberculosis, and you have really shown that which test has to be done and which not. Very clearly, I think the message has gone very clear. The only thing I just want to say, when you take an endometrial biopsy, now biopsy is not taken, it is an endoaspiration.
Yes, ma'am.
All walls should give the some amount of tissue, we should go there and we will be able to know that whether it is going for the culture or whether going for the biopsy or for histopath or for the gene expert. When I did the project of Gene Expert. It was very at initial stage in 2010. And then it was very much required that we should just wash it repeatedly. So there should not be any blood contamination with that. This is very much important. So all these finding, wherever people are sending for the Gene Expert, they should know how their lab is. And finally, they should be able to get the proper diagnosis. I want the comments from Dr. Gauri also.
Dr. Rashmi, it was really a very elaborate talk. I'm happy that so many participants are there. At least if these people can convey it further also, there's a lot of anticox treatment will stop. You know, the patient doesn't conceive, take 3 months anticox.
Yeah,
They
that's so
don't
true.
realize how much of a resistant cases are coming, and then you have to treat for MDR. So one has to be very careful, and you have conveyed it nicely. One more diagnostic that we in our center, when we send the specimen for chronic endometritis, there also they test the mycobacteria.
Okay, ma'am.
And they give us sometimes the sensitivity also, what is known as a DICE test. So once in a way we get it, but we just don't go by their test. If they say that, we specifically test for the tuberculosis, what we usually do is the Gene Expert.
Yes, ma'am.
That's what we do. And since we have a lot to talk about treatment and all that, I'll wind up here. Excellent lecture, Rashmi. Very good lecture.
Thank you so much, ma'am.
Yeah.
You have to chair the next lecture as well, ma'am, by Dr. Seema Mittal.
Is it?
The next lecture.
Dr. Rashmi by Dr. Meenakshi.
Meenakshi. Yeah, it's by Dr. Meenakshi.
Dr. Meenakshi, yeah, Dr. Meenakshi, yeah.
As we continue our journey, it is my honor to introduce our next distinguished speaker, Dr. Meenakshi Dua, Secretary of the IFS Haryana Chapter, to speak on the endometrium in genital tuberculosis. Can the endometrium recover?
Good evening, everyone. On behalf of Haryana Chapter, I thank SIG Genital Tuberculosis for giving me this opportunity to participate in the group. And let me just share my screen. Yeah, it's here. So, without wasting time, I will start with my presentation. Can everybody see my slides?
Yes, Dr. Meenakshi. But
Yes,
make it full
yes.
screen, please.
So the topic given to me is the endometrium in genital tuberculosis. Can the endometrium recover? Whenever the diagnosis of genital tuberculosis comes to our mind, we are always worried about endometrium. Once it's damaged, we have this impression that, you know, it's not going to recover and it is going to be affected for all the time. So I'll be covering my talk under the following headings. First, I'll be talking about the impact of tuberculosis on the endometrium at the cellular, molecular, and the immunological level. It affects all the three levels, and what all therapies we have for the different degree of damage and how much it can improve. So starting from ATT, histoscopic adhesiolysis, estrogen therapy, then we have this PRP, then probiotic, and the future, what is if we have any future therapy for the same. As Dr. Rashmi elaborately told us that how tuberculosis is affecting the whole genital, female genitalia, genital organs. So it has been seen that tuberculosis affects around 50 to 90% of the endometrium, and it affects at the cellular level, which leads to the damage and causes the change in the physical and the structural damage. So there's granuloma formation in the base endometrial layer, then that leads to the glandular destruction, and then further it can invade even into the myometrium. So that all leads to the intrauterine adhesion. There is architectural distortion of the uterus. Even the lining sometimes get thinned out. All of it together, it leads to menstrual irregularities. The patient comes with, you know, either with heavy flow or with minimal flow or no flow. They also come back to us with recurrent pregnancy losses and even recurrent implantation failure. In IVFs also, we see it's very difficult to make these patients pregnant. Even if you put a good embryo, sometimes it doesn't implant. So going into the detail of it, this tuberculosis, it affects both It affects cellular and molecular level both. Sorry. So talking about the granuloma, there is increase in, whenever this tuberculosis infection happens, there is increase in T cells and macrophages, which invades into the functional layer. And if the infection is not stopped, it can even invade the basal layer and the myometrium. There is matrix degradation by the destructive enzymes. So there is complete damage done. And healing in tuberculosis is always by fibrosis. So ultimately, when healing happens, there is adhesions, which leads to Escherman syndrome. It's not just the physical damage. Along with that, it also affects, there is downregulation of VEGF, vascular endothelial growth factor. This is responsible for the subendometrial vascularization and blood flow, which is required for the endometrial receptivity. So that is also reduced. Also, further genes like HOXA10, LIF, which are required, for the implantation, they are also less expressed. This leads to destabilization of the implantation window. So even if the endometrium looks fine, because of this immunological changes, sometimes the embryo just does not implant or doesn't invade. We get more of biochemical pregnancies in such cases. There is also immune dysregulation, and this starts right from the beginning once the patient gets infection. It's not in the advanced stages. It starts as early as the infection sets in. So there is Th1, Th2 imbalance. We know for a healthy pregnancy, we need more Th2 and less Th1, but the shift is reverse. In tuberculosis, there is increase in Th1, which leads to increase in tumor necrosis factor and IL-2, and that is why the embryo does not implant. Also, there is elevated immunomodulators like HLA-G, ILRA1. This also, again, the reproductive immunotolerance is disrupted and it does not implant. Apart from that, mycobacteria also affects the metabolism inside the endometrial cells, and that also affects the endometrial receptivity. So at each level, tuberculosis is affecting. Now, once the infection has happened, can this endometrium recover? The answer is simple. If you have diagnosed it early, then yes, there is a good chance of recovery. If it is diagnosed late, then the chances of recovery is less. So as long as the infection is localized to the basal layer, anti-tubercular treatment works very well. There can be lining regeneration. All the cells, whatever destruction it has happened because of Mycobacterium tuberculosis, it can reverse. Inflammation can come down, granuloma can disappear, the blood flow can improve, and the fertility can restore. There are many studies which have shown that patients have conceived while taking ATT or immediately post after ATT. Even with IVF, the results are better post ATT. So definitely it works, but the infection has to be limited to the basal layer and not beyond that. And there should be early diagnosis. But what happens when the diagnosis is late? Definitely, because this infection would have invaded the basal layer, and that leads to fibrosis. So because of the fibrosis and the burnt out of the endometrium, it becomes less responsive to the hormones. And because of that, the walls, anterior and posterior walls of the uterus, they oppose and they form adhesions and leading to Asherman syndrome. This is a scary situation and very difficult to treat at times. But what do we do in this situation? So how do we assess that the TB post, after you have finished the ATT, what is the outcome, whether there is damage to the endometrium or not, and if the endometrium has recovered? So there are different modalities which are available. 2D, 3D ultrasound is good enough, though it has less sensitivity but higher specificity. Diagnostic hysteroscopy is best to identify whether there is any damage to the endometrium. And also a repeat endometrial biopsy can be done to confirm whether the infection is complete or not. This is a study which was published by Dr. Sharma in 2016, which shows that how ATT has helped in the adhesions which were formed before because of the tuberculosis. So what they have done is they've done histoscopy in patients pre and post ATT. So you can see here the patients who had pale looking endometrium, it is almost gone post ATT. So there was definitely there is improvement is there, but most of the improvement has happened in grade 1 adhesions, the milder adhesions. When the adhesions are severe, it does not help much. It will just heal the lesions and ultimately there'll be fibrosis, but it will not reverse the adhesions. So what do we have next if we still have intrauterine adhesions? So once the ATT is finished and the infection is eradicated, other modalities are we can always do a hysteroscopy, adhesiolysis. Adhesiolysis, you all know, it should be done with a cold knife rather than doing any of the energy sources, because that can cause more damage. And most of the times we add estrogen therapy to that. The other modalities are PRP and probiotics during the treatment. I'll be coming in detail on all of this. So coming to this study, this was a very interesting study. We usually, what we do is, once we have done the surgery, we will put the patient on estrogen and then see her after 6 weeks or 8 weeks, and with maybe a intrauterine device or not, depending on the severity of the adhesions. So this study, this is actually from Germany. They did a randomized control trial. They included almost 50 patients in 2 groups who had intrauterine adhesions. They had done the surgery. They gave the treatment, and after the treatment, they did the surgery, and then in one group, the usual care group, they gave estrogen therapy, and the other group, they did not give estrogen therapy. In both the groups, they have put intrauterine device, copper T or multi-load, but in one group they gave, in another group they did not give. And then they checked after 6 weeks what was they did a relook hysteroscopy, and they found that the chances of intrauterine adhesions post treatment, you give estrogen, you don't give estrogen, it was just the same. There is no extra benefit, but the patient had less side effects, but because they did not have to take estrogen, so the side effects and the daily quality of life was better without estrogen. Even the grading was almost remained the same. Even patients who did not have take estrogen but just IUD was there, the adhesions they did not increase. Also, once they removed the IUD, the time to conceive, you can see here, with estrogen and with the usual care, without estrogen and with the usual with estrogen, both cases they conceived in the same time. The number of pregnancies were the same, almost 80% conceived. So it was more of the mechanical thing which helped rather than the estrogen therapy. There's another paper from China. They have devised this new device, you can see, something like Mirena, but it contains estrogen. So this is a silicone rubber stent which will be put in the uterus, and it will release estrogen. So what these people did, they again did a multi-center randomized control trial in which post hysteroscopy, in one group they have given oral estrogen therapy, and another group they had put this drug releasing stent, estrogen stent. And what they found, because there was local release of the estrogen, and this, you can see it is in triangular shape, so this did not allow the anterior and posterior wall to oppose. So that really reduced the adhesions. So they repeated hysteroscopy after 60 days post surgery, and they found there was 50% reduction in the adhesions compared to the control group. They had, again, it had formed. Also, the severity of adhesions which had formed were much less compared to what was there with the estrogen, oral estrogen therapy. Otherwise, the pregnancy rates and all were same. Another interesting thing what they did was they actually measured the serum estradiol levels. So the baseline levels were same in both the groups. Where they gave oral estrogen, the levels were much lower compared to the local one. Even with that, the serum estradiol levels was much higher. And maybe that is again the reason that the regeneration of the endometrium was faster, and that's why the adhesions did not form, along with the mechanical barrier which was there. So again, 2 studies, both are randomized control, but both saying the different things. But probably this is a very good device if it's available. Then in place of the intrauterine device, what we usually put, we can start using this. Then coming to the PRP. For all thin endometrium patients, we always try and make it better with we try PRP. So PRP has been tried. I couldn't find any paper specifically for tubercular endometritis, but yes, there was this study from a Chinese group again, Chen et al., which was published last year in cases of chronic endometritis. So what they did was, after the histopathological diagnosis of chronic endometritis, they gave doxycycline for 15 days. and after that they did the embryo transfer. In patients who did not conceive after that embryo transfer, those patients they included in the study, and half of them they put PRP, and another half they did not give PRP. So the pregnancy rate did improve. Miscarriage rate was less in group which who had PRP. Also the endometrial thickness was better. Live birth was better. Also they did multiple PRPs. In some of the patients, they have done 3 or 4 times PRP, and that also helped. Though it did not improve the clinical pregnancy rate as such, it was not statistically significant. But yes, the live birth rate was statistically significant. So PRP also in patients with thin endometrium post treatment, once the TB is completely cured, we can think of, not when she's under the treatment. Once it is finished, it can definitely reduce the inflammation and improve it. Now coming to probiotics, as we all know, probiotics is something which is going to modulate the gut bacteria. So when you take tubercular treatment, these are very strong antibiotics, and most of the patients are not able to tolerate. They have lots of side effects, and because of side effects, sometimes they stop it. So there are studies where they have added probiotics along with ATT for the first 2 months, and they have found that the tolerance to ATT is much better because the gut barrier is maintained, and because of the better tolerance, they don't miss the drugs. The patient compliance is better. Also, it causes immunomodulation, so inflammation is low. The damage from the tuberculosis is much low. It releases anti-inflammatory metabolites, so healing is faster. The gastrointestinal hepatic side effects are less. So once we have patients who have been diagnosed with tuberculosis, we can always add probiotics to the treatment, and definitely that will improve, and the recovery is going to be faster. Now, these are some few things which I've shared. Now, what about the future directions? Do we have anything new coming up? As I told you, this tuberculosis, it acts on the molecular level. So a lot of work is going on that. We know tuberculosis, it affects the uterine receptivity. It affects the cell adhesion molecules. It reduces their number. So the blastocyst does not implant. The VEGF, LIF is less. So then the embryo doesn't implant. It also affects AMH. We always see patients coming with low ovarian reserve in tuberculosis. It causes more of implantation failures and abortions because of increase in APLA. Then again, even the cytokines are affected. So there is a lot of work now going on the nuclear receptors. Nuclear receptors are something which are very cell specific, and they are the ones which are involved in uterine receptivity, immune modulation, and TB modulation, all of it. So they will, if this comes up, it is going to be molecule specific. So they are working on it for better, faster diagnosis of tuberculosis, which is one of the very difficult tasks to do. So we'll have more quick diagnosis, more specific. Even we can prepare drugs which will work on the specific molecule, so the recovery is much faster and the side effects are much less, and it will definitely affect, if it will cause immunomodulation, so the pregnancy rates are going to be better. So the whole work is going on to get a better and a better identify, better biomarkers, better diagnostic, and faster and quicker treatment, which causes less disability to the patient. So this is from my side.
Thank you, ma'am, for your insightful and comprehensive presentation. I would like to request you to address a few questions. I would like both the speakers to address a few questions. Dr. Sadhna Gupta has requested to conclude your view on TB Gold.
So before that, I would like to speak to
Yes.
Meenakshi. She has shown a very good study of China and Germany. But these are I believe, is the preliminary study.
Yes.
And it's not RCT, it's not a big meta-analysis. So it requires really, we have to wait for this. Because I remember my old time, I'm an old timer. So we used to put the lippies loop or sometimes the silk thread, nylon thread inside. But copper T and some IUCD with the copper device was not really, because it causes more and more infection, adhesions.
True.
That was not enforced.
But this Mirena kind of a thing, which is made up of silicon, it is not reactive. I think if this comes, it will be really helpful. And it is exactly that triangular shape. So it will not allow the anterior and posterior wall to, oppose.
So we need this kind of
Yes.
IUCD which should not adhere.
Yes.
And the
Just block the
anti-epileptic wall
cavity.
should be apart. That
Yes.
is most important. That is there. And you have shown the PRP result. It looks very, very fascinating. So I believe
But
with
it's on
time,
chronic endometritis and severity was not mentioned. So we
they
don't know, maybe for the, minimal patient who had very little infection, if they're doing PRP, we don't know.
Not only that, Dr. Sudha, the German studies, no, they don't find tuberculosis so much.
actually,
It
yes.
could be other reasons which cause such sort of additions, and they have found the results. Cox damage is much more severe, as Dr. Rashmi said, if the endometrium is affected. And that reminds me, I saw a study by Dr. Neeta Singh from All India Institute, where she had used stem cells. It was bad Asherman's with amenorrhea, where it was only 10 cases where they had used stem cells. And what she said was that out of 10, 4 or 5 of them resumed periods.
Stem cell, ma'am, if it is used properly, it is a very good tool, but they should be able to prepare and identify those cells.
We as
don't know that.
practitioners, it's very difficult
Yeah.
to.
They can do, they have a good lab, they can identify those exact cell, mesenchymal cell, which have to be put. It will definitely help. There's so much work going on stem cell.
Yeah, but as Dr. Sudha Prasad said, no, this Chinese, German, they have not specifically looking for Cox. We are all the time worried about Cox.
We are just struggling with the tuberculosis,
Exactly.
genital tuberculosis, like in unexplained infertility. We do not know. We are putting good blastocysts, and even though the pregnancy is not occurring, and many times the thin endometrium, we are just scratching our head. Ki kya ho gaya isko? We are doing so many
Ma'am, I
things.
just wanted to know, what if we remove the copper from the tea? We remove the copper from the tea and then we put it as a barrier?
Then it can work.
That is what we are doing in some cases.
Silicone, because the copper is the thing which
Yes.
can cause more and more.
So we are just removing that loop. It is very easy to remove. Just open and it is removed, and then we are putting it back.
But the another thing, it can poke.
No, ma'am, take
it is not a round shape like
So
mirror.
the new 365 one is like this shape.
Yes,
so we are
that
putting
can
that
work.
after removing the copper.
365 can work like, yes. So
Dr. Rashmi, few of the panelists have to leave. So can we have the discussion a little later?
Yeah.
So we start the panel. Can we do that?
Yes, I think so.
Okay, please carry on.
Yes.
Ma'am, we would like you to please stay and opine on many things, because aapka experience is more important than anything. Please stay for some time. Gauri ma'am, please.
Yeah, sure.
As we now move into the most interactive and thought-provoking segment, which is the panel discussion, Dilemma of Diagnosis and Management, along with ART, case-based discussion. It is my privilege to introduce our esteemed moderators, Dr. Seema Mittal ma'am, co-convener of IFS SIG, an esteemed clinician, teacher, and respected voice in the reproductive medicine, known for her balanced clinical approach and academic contributions, along with Dr. Nisha Bhatnagar, co-convener of IFS SIG, known for her clinical expertise, balanced perspectives, and dedication of advancing reproductive medicine. May I now request our moderators to kindly introduce our eminent panel experts and take over the proceedings for panel discussion.
Can you see my screen? I'll just start with introduction. I think we have very short of time, so I'll introduce our experts. Dr. Sonia ma'am needs no introduction. Everybody knows ma'am. She's she's done a lot of work in infertility and tuberculosis specifically. And Dr. Umesh Jindal ma'am, she's also our expert. She also has done a lot of work in infertility and tuberculosis. So Dr. Seema ma'am, can you please introduce our panelists?
Dr. Seema, you will have to unmute yourself.
Sorry. Okay. Thank you so much, Dr. Rashmi, for organizing such a wonderful interactive session, and all the information by you and Dr. Meenakshi were very, very helpful, and it will go a long way in our practice. So I take this opportunity to introduce my further panelist here, Dr. Leena Vadva. She's professor and head at ESI, and she's been working on infertility and Indian Fertility Society since long. Dr. Priyanka, she's a professor at Kalpana Chawla Hospital, Kalpana Chawla Medical College, and she has got many publications and awards. I will be just moving fast. Dr. Shalu Gupta, my dear friend, she's the clinical director at Cloud9 Hospital, and her special area of interest are poor ovarian research, PCOD, and recurrent implantation failure. Nitasha, my dear friend, and our joint secretary, Haryana Chapter, she's director for Fertility, Zirakpur. Her special area of interest are fertility enhancing endoscopic surgery. Dr. Vandana, she is a senior consultant in normal fertility IVF. Dr. Manju Handa, she's radiologist at Handa Imaging Center, Delhi. Dr. Charu is microbiologist with 20 years of experience. I think we need her inputs the most. And Dr. Mudgal is he's the senior scientist at Life Sciences. So we will start with our first case. Most of the things are discussed and well elaborated. So we'll be just skipping the history, and we will go to the first case directly. There we will discuss everything. So we can just go to case 1. Because rest will be taken in the cases, and me and Dr. Nisha will be discussing. So we go to case 1. Further, we move further.
Ma'am, this is the case 1. I think I'll just read out
No,
the case.
case one is beyond this. Dr. Nisha, we can just skip one more
Okay.
slides. Yeah. We can go further. No, which is before the yes. So we start from here. So there is a 28-year-old woman who presents with 3 years of primary infertility. She reports irregular menstrual cycles, mild pelvic pain, and occasional low-grade fever. There's no cough or weight loss. So my question to my panelist, Dr. Leena, is there. What subtle symptoms of genital tuberculosis should raise suspicion in this patient?
Yes, Dr. Seema. Good evening. In this patient, we know that she's having primary infertility and also irregular cycles. And apart from that, she's having mild pelvic pain and also typical history of occasional low-grade fever, although there's no cough or weight loss. But if a woman is presenting with such subtle symptoms, one should keep in mind the suspicion of tuberculosis and investigate further.
So can you add anything to this, Dr. Leena? You must be getting lots of patients of tuberculosis also and infertility also. So can you add something to this, because we don't get this clear picture. It is only for the presentation. So
okay. Basically, am I audible?
Yes, you are
you
very much
are.
audible. Yes.
Okay. So we need to differentiate from endometriosis, which is a very important differential in cases of tuberculosis, and sometimes both can coexist also. So in this, you have to differentiate like on the basis of symptoms. If the patient has endometriosis, there will be typical history of dysmenorrhea, dyspareunia, dyschezia, urinary symptoms. So that is very particular. And in tuberculosis, also the patient may have present with dull aching pain. And in the initial phases, the patient will present like with menorrhagia, the symptoms similar to PID, but later on there may be scanty menses because as there is destruction of endometrium, the patient may present with scanty and irregular periods also. So in tuberculosis, it's not necessarily linked with the menses, but endometriosis, the pain is cyclical. Dyspareunia, dyschezia is already mentioned. And apart from that, with TB, as in this patient, some constitutional symptoms like patient will say बहुत थकान होती है, शाम के time बढ़ जाती है, हल्का बुखार रहता है, and then further investigation has to be done in such cases.
Right. Thank you so much, Dr. Leena. My next question is to Dr. Priyanka. Dr. Priyanka, since you people all are working in medical colleges, you have much more exposure. So, Dr. Priyanka, I want to know, are any asymptomatic cases of genital, do you have any, do you know about asymptomatic cases of genital tuberculosis, which are common in infertility cohorts? Like you must be getting lots of patients who are not symptomatic, but they are they turn out to be tubercular, or sometimes like we had the trend of giving empirical ATT and patient used to respond when we were doing post-graduation. So just tell
Right.
me how, tell me how many
Yes,
asymptomatic
ma'am.
cases.
We do have such cases. It has been reported around 12 to 18% of the cases which come in our OPD. They're generally asymptomatic. And the diagnosis is like a diagnosis of exclusion, that you rule out all the things and they are not responding to any long-standing antibiotic treatment also. And even what happens in periphery is that single test is done and that turns out to be negative for TB, then people don't even think or consider starting ATT. But it has been found that if we give a course of ATT in such cases, they generally start responding. So my point of conveying here is that sometimes patient is asymptomatic, but then you have to start ATT, empirical treatment, then only the patient.
But
So,
Dr.
like,
Priyanka, that is the point we are trying to avoid,
yes,
because so many times it
actually,
is started empirically without any diagnosis. So the whole idea is to first diagnose and then start that, because so
So
many
in
times it is
diagnosis,
done that on clinical basis, empirical treatment is started, patient takes for 1.5 months, changes the doctor, stops in between, and
yes,
multiple
yes,
problem arise.
it happens that way.
Can I add one more thing, Priyanka? The
Yes, ma'am.
reason why patients conceive when they are on ATT and we don't have a reason is because rifampicin has been an immunomodulator.
right.
If you
Right.
read about rifampicin, you will understand that it is an immunomodulator and somehow it modulates the immunity of the patient and which helps in conceiving the patient.
Yes.
It was not because we have treated the ATT and that is it. So
Right.
there are
So there
papers,
is
some papers we read about it. We can come to know rifampicin. I was just reading why patients conceive. My question was why patients conceive on ATT in spite there was no symptoms and what is happening? Why this is like a became a miracle done somewhere around 15, 20 years back. So
Yeah.
then I came to this, rifampicin is an immune modulator.
right, ma'am.
Very, very right, Dr. Shalu.
So what we do is that we depend upon a composite reference scheme only, a composite reference standard, wherein clinical suspicion along with lab investigations and direct visualization during histro and laparoscopy only helps us in concluding the diagnosis.
Yeah,
Very
that is the
So,
biggest dilemma, because we can't post everyone for laparoscopy as well.
yes.
So that is
But
why
then,
the whole confusion. Yeah. So,
yes,
okay.
but then we have to subject patient to multiple samples. And if
Yeah.
either of them comes positive or even a strong clinical suspicion is there, then only we can start with ATT in those cases.
So as per the study, almost 60% of the cases of genital tuberculosis are asymptomatic, and they may not come with infertility. They might have other symptoms or other disease or disability. Say some people will come with amenorrhea only, or they will have weight loss. So
Right.
that finishes this case. So over to Dr. Nisha for second case.
Now we just want to see that what should come to your mind when you are thinking about tuberculosis. This is a 35-year-old female with secondary infertility. She has bilateral hydrosalpinx on ultrasound. She lived in a TB endemic region. What key features in her history or examination would support TB versus pelvic inflammatory disease? I think anybody can take that. Dr. Shalu, can you take that, please? Dr. Shalu, you are muted. Dr. Shalu, you are muted.
I think she was in car, so maybe
No,
Natasha
she's
can take.
muted.
Natasha can take this question if she.
Hello?
Natasha, yeah, we can hear you now.
Hello? So in this patient, when we see this with the hydrosalpinx, we have two things in the mind which comes is one is infection and other is tuberculosis. The tuberculosis comes in our mind because she was in the endemic region until the age of 20. So this is the two things. So we need to understand in the history, yes, this is it. In the examination, when we do the examination, the uterus may be normal, but when we do when we go and the adnexa, we'll be feeling the fullness here. Apart from that, we can do her basic test, the workup, a chest X-ray we can do for her, and then we can go and can speak to explain her this. This can be because of the tuberculosis. And here, as Dr. Rashmi said, the best thing is to go for the endometrial biopsy in these kind of patients to make sure that we don't expose her to unnecessary things before we plan the further treatment for her.
Dr. Natasha, would you like to add something to it? Dr. Leena?
Yeah, I think a basic ultrasound I would like to do first in this patient. And along with that, we can monitor the endometrium also, which has been discussed. If the endometrium is not growing and we are getting hydrosalpinx with that, then we should investigate further. And the first thing I would like to do is endometrial biopsy. And all 4 samples, TB, AFP smear, and culture, gene expert, and histopathology should be sent. And apart from that, ESR, Montux, and X-ray test, that's a routine which we are doing. And then further decision, if required, on examination, there are tumor masses, and if they are confirmed on ultrasound, and if needed, MRI can also be done for that. Then, and patient is having constitutional symptoms, then we need to take a decision whether ATT is to be given or not.
Ma'am,
I'm glad Dr. Manju Virmani is here with us. She's a very senior radiologist. Ma'am, Manju ma'am, would you like to add on? Dr. Leena said that ultrasound will help us in guiding. So can you tell us which exactly signs we would be you would be looking on ultrasound? Dr. Manju?
Ultrasound should be the first modality of choice, and I agree with you completely that we look for hydrosalpinx. I mean, when we see fluid in the endometrial cavity, the first thing we should do is dilated fallopian tubes. And if they are dilated, then we can look for the ovaries. What kind of hydrosalpinx? Is it just unilateral, bilateral? Is it pyosalpinx? And that sort of picture. And obviously, we have to make sure they don't have an abscess. And that we can differentiate it clinically because she'll be clinically symptomatic. Tuberculosis patients may generally be asymptomatic. Lining, endometrial lining is another very, very important factor, which you've all just talked about it. I've been listening to it. And that makes a lot of difference because endometrial lining generally is thin and doesn't grow. So if we do it in this early cycle as well as late cycle, we'll find the endometrial thickness essentially being not changing at all or being thin. And look for
do you see a lot of, can you pick some adhesions or something on ultrasound?
Yes.
If you
3D ultrasound, actually, there was a very good picture with somebody. It's a classic 3D ultrasound. We'll see a defect in the endometrial cavity. And it's not that we can't do it on a 2D. 2D actually shows you a complete defect, which may go from one end of the endometrium to the other end. So on a 3D, it's beautifully documented. So I always do a 3D ultrasound in these patients to document the adhesions. And should be one more which I would like to actually add is to look for sinecure adhesions. It's better to do in the post-ovulatory or secretory phase when the endometrium is better developed and not in the pre-ovulatory phase.
Usually we do the scans in pre-ovulatory or mid-cycle. So you
Mid-cycle
suggest
still okay. But to be calling adhesions at immediately post-menstrual is very difficult. If because it's like a monolayer echogenic thin endometrium. So I prefer doing it in the mid-cycle or, 10th, 12th day is fine. But secretory phase will pick her up much better.
Dr.
And madam,
Natasha,
what about this TO masses? Sometimes they give the picture of endometrioma also. I'm having one patient with bilateral TO masses and the MRI reported hematosalpinx with endometrioma. Can both coexist or how we are going to differentiate?
Okay, it's because once you start the endometrioma, in endometrioma, the process can get extended into the fallopian tubes, that we all know. And we should look for whenever there's a dilated fallopian tube, which is adherent to the ovary, and we see similar internal echoes, we know that there is going to be the endometriosis extending into the fallopian tube. And I don't think we need MR. I think good ultrasound will give you all this information.
Okay, thank you.
A word about saline infusion sonography, will that be helpful? Should we do that or should we avoid that?
No, that's fine. Saline infusion sonography is actually pretty good when we're looking for endometrial lesions. We want to rule out adhesions. We want to rule out polyps. And so
the tubes?
Actually, polyps I don't do, but for adhesions, one can do that. And that gives us enough information. And the other advantage of saline infusion sonography is when we are looking for patency of fallopian tubes, where we cannot do an HSG. So my first thing for a patient of tuberculosis is to do an ultrasound and not a HSG, because ultrasound will give us the free fluid, will give us more information. Is there any pelvic infection? Because if there is tuberculosis and there is pelvic infection, this women will get peritonitis by doing an HSG. So those are the patients with saline infusion sonography or contrast enhanced hyposis system will give us much more information.
Thank you, Dr. Manju.
Thank-
Dr. Natasha, you were saying something. You want to add something to this?
I was actually saying that in case this patient has already come with bilateral hydrosalpinges, she has infertile. We know she is from an endemic area. I know we have to support our diagnosis by really, taking out something like maybe endometrial biopsy for gene expert. But I think it's not unwise to talk to the patient to go ahead with laparoscopy and as well treat her and see for the further if we can see any laparoscopic findings as well as do the hysteroscopy together. And then, we can do some the gene expert test and the other histopathology test to prove our diagnosis and put her on treatment.
But Natasha, yeah, I would like to be, should not we diagnose in case she has a tuberculosis prior to putting a laparoscopy in case it is active? If we give her 2 months of ATT and then take her for laparoscopy, it will be much more for her healing point of view and all the lesions which are there. That is one my thought process. What do you say?
And endometrial biopsy is non-invasive. If it comes positive, better to start ATT first and then think
Then-
about it.
The laparoscopy part, yeah.
But
that
how
is
many
what I was
times endometrial biopsy comes positive, Dr. Leena?
Every time, ma'am.
Agreed.
It's negative.
Agreed. It is very rare, very few samples because
Yeah.
it is a bossy bacillary. But since the
bacillary.
patient is presenting in such a way, it is better to rule out because if it comes out positive, then we should treat it first.
Okay.
So I want one take-home message here. What should we do when we are suspecting? Okay, one thing is multiple tests should be done. Second thing is a good 3D ultrasound should be done. And if you think that you are suspecting, what should be your next step? Laparoscopy or
I'll go for endometrial biopsy first.
biopsy?
Endometrial biopsy, prove the diagnosis, and then we can go ahead.
Then proceed for history.
Okay.
The reason, again, one of the things is supposing endometrial biopsy later comes positive, then we can be in a medical legal suit because in case anything happens post the lab,
Yes.
that she's
Okay. So endometrial biopsy is the next step.
they can always come back to us saying you should have done it prior.
But Dr. Shalu, have you seen any endometrial biopsy positive case in your practice?
Ma'am, very rarely. Yes, I have
I
seen.
have not seen any case
of
positive.
course,
I
of
have
course.
We have done a thesis and gene expert, we are seeing coming positive.
Yeah, it comes positive. Even
it came positive. Yes,
yeah.
yes.
What percentage? How many cases?
Maybe I can have word from my experts. Dr. Sonia ma'am. Ma'am, please guide us.
No, I'm not guiding. I'm just saying that yes, what you have been discussing is correct. Endometrial biopsy should be done first before putting in a laparoscope because sometimes you may flare up the TB. It may be just latent, and you by intervention can it can become it can become active once you have done the laparoscopy. So and of course in this case there is hydrosalpinx already present, so there are chances that she is already tubercular. But still, it is better to prove it. And now we are very, very careful about it because the guidelines are also saying that it has to be, first proven and then you put the patient on ATT rather than just doing it. So you should do an endometrial biopsy first. And it is wrong to say that it never comes positive. It does come positive. It's not right. It's not that way. It does
Ma'am,
come.
it is endometrial biopsy or endometrial aspiration, like Sudha ma'am said.
Whatever you want.
Or would you like to put a hysteroscope simultaneously?
Actually, see, whenever I'm the old school again, like Dr. Sudha was saying. So for us, we were taught to do an endometrial biopsy or an aspiration first, not put a hysteroscope first over there. So basically, the first step would be to do an endometrial aspiration or biopsy, and then whatever the result is, based on that, you take the next step. I wouldn't like to do the laparoscopy first of all.
Yes, just to add on, madam, now we are not using curate. The curate is out. We are using carbon standard number 4 or a PIPL for doing
PIPL. Everybody is using. Yeah.
I would like to add here, madam.
Yes.
Endometrial biopsy is a right sample type for diagnosing endometrial TB. But the problem here is we may not know labs will use complete biopsy for the testing. For example, either gene expert or NAT test or real-time PCR specific to TB also. They will take minimum of 50 milligram to 100 milligram of biopsy. So if TB may be there in the left or right quadrant, you would have collected both the quadrant biopsies will be there in the sample container. We would have taken the wrong sample for the processing. That will lead to false negative report. And when you are strongly suspect, if you provide in a clinical history while sending the sample, we will repeat the same test with the other biopsy also. because we are not going to take the liquid fluid from the container. We will take the tissue biopsy only. We have to digest that. Since it is intracellular pathogen, it is little complicated to identify. That is the reason it's a possibility we get more false negative report. Still, we get positive when there is a strong positive, strong infection is there. Obviously, we get TB positive by gene expert as well as TB PCR.
So, sir, should we be taking different biopsy from different cornu in different, containers?
Yes.
Like we used to take for CA endometrium earlier.
Correct. If there is if it is a video-based guided sampling, you may confidently can take only one biopsy. When it is randomly collected, it is better to take in the right, left, right quadrant. You will get better outcome from the diagnosis perspective.
Yeah, we take from all walls, but we put it in one container only. We don't label and.
But we will not take all the biopsies to taking processing, madam. For example, you may take almost 200, 300 milligram biopsy will be there. But for a gene expert as well as PCR, we take only 50 or 100 milligram maximum. So in that case, we may miss it out. That's the reason minimum should be about 10 bacilli should be there to detect by molecular method also. So this is the problem where we are missing out in the diagnosis. And there is a TB PCR, people may think, Dr. Sharma also, I have discussed with him. So what he has suggested is conventional PCR method, where it is gel-based run, they have to run, that is old method. Nowadays, nobody is using it, only few labs may use it. But we use real-time PCR, it is equivalent to gene expert. Same principle, what is gene expert using? Same principle we do in the open system, because when you strongly suspect a TB, when you provide a biopsy, we repeat test and with the next volume, we get better opportunity, because if there is only 10 bacteria there, the PCR will say only, it will pick up only if it is 1000 bacilli reaches. If it is only one bacteria there, it takes time to reach 1000 copies. It's like Xerox machine. So machine will need minimum 1000 copies to say positive flag. So when it is open system, we will do repeat testing from the same sample again, we get that positive rate. So our clinician and microbiologist should be connected. When you strongly suspect for TB, please inform the microbiologist. They will recheck and they will come back with you a good report.
Ma'am, maybe it is a good idea to take 2 biopsies in 2 containers. Sonia ma'am, what do you say?
Dr. Nisha, Dr. Jindal is also there. She's about to
Ma'am,
leave.
Umesh ma'am, please tell us what is your opinion about taking 2 biopsies from 2 cornus and putting it in 2 containers?
I've never done it. I wouldn't be able to say.
How will it eventually affect the treatment? Once it is diagnosed, the treatment has to be initiated anyway.
No, he is saying that we might miss if we take the whole sample in one container and he is using a small bit of that, then the remaining we might miss the remaining part, because if we take 2 containers, he'll take a bit from this, he'll take a bit from this, and then maybe we'll be able to reach the diagnosis better.
Cost effectiveness will not be there.
Dr. Nisha, with people already the tissue is so less. Our microbiologist says that give us little more sample, because by
exactly
is already less.
Very right.
True, madam. And one more thing, blood stints will be there, and the antiseptic solution washed during vaginal wash also will give a cross contamination. That is also look like a PCR inhibitor.
So, any solution for this? What to do?
My doctors, they suggest they use first saline wash they do on the vaginal, and taking the sample very carefully without cross-contaminating with other antiseptic solutions or any antibiotic exposure. Okay. Especially antibiotics should be avoided before doing this procedure.
Okay. Great.
Agreed.
So we move on. So we have a lot of TB of vulva and vagina also, which may be sexual partner, may be the source of infection. And in the vulva, it begins as a nodule on the labia, irregular ragged ulcer, sometimes with sinuses discharging caseous material. In the vagina, it may simulate carcinoma in its gross appearance. So prioritizing TB testing despite no symptoms. In this case, we had bilateral hydrosalpinx, but even if no symptoms are there, the key message is that we should do multiple tests on the same person, no saving money here, and reach the diagnosis.
Yes.
So these are the differential TB tests for diagnosis: MON2, menstrual blood, ultrasound, antibody, gene testing, TB gold, endometrial biopsy, AFP culture, histoscopy, laparoscopy, then urine culture sensitivity. Sometimes HIV also have latent this thing. Latent TB and infertility, the TB can cause progressive silently. Tubal damage is there. and it is often discovered during infertility treatment. I think we discussed how will we diagnose. So now this is the third case. Ma'am, do you want to take Dr.
Yeah.
Seena?
Okay. I will take this case. So this is 30 years old female with unexplained infertility. She has normal HSG and negative TB culture or PCR from endometrial tissue. Laparoscopy reveals tubercles on the peritoneum. So first part is how reliable are standard TB tests. I think we have discussed in details, very well elaborated by Dr. Rashmi, and I think no questions are left unanswered. Said what additional investigations, that is histopathology and other studies, this also we have discussed. So I would go to the third part because we are already running short of time and we have our panelists who will answer this question beautifully. So this question is to Dr. Natasha. How will you manage a patient with negative test but strong clinical or imaging evidence of tuberculosis as talked by Dr. Manju? Dr. Natasha?
चल बस कर ले है ना जरा पे ना
Ma'am, we know we have to now send a battery of tests before we are, confirming the patient whether the patient is having tuberculosis or not. Having said that, on laparoscopy, we are finding that there are tubercles. Itself, we can actually start the patient on an ATT according to me. But then I think, ma'am, that was a question I didn't want to.
Yeah, Natasha, but tell me, all tubercles on laparoscopy suggest tuberculosis?
No, they might be present.
Yes.
Them don't. All
So first, this question I think all my panelists can answer. If we find some tubercles on laparoscopy, so are they suggestive of tuberculosis, Dr. Lee?
I think we want opinion of everyone. Please, please opine.
Not only isolated tubercles, if you find findings suggestive of chronic PID, suppose adhesions are there, omentum hanging, bowel here and there stuck, and you find tube masses, conglomeration, other associated symptoms are there. In that cases, you are justified in starting ATT.
Dr. Charu, you are there? Dr. Charu is there?
Dr. Charu? Dr. Murugan? Dr. Charu?
Yes, ma'am. Am I
Dr.
audible?
Charu, tell us
Yes,
what
you
you
are.
suggest. Our patient has got tubercles on laparoscopy. So as a microbiologist, what would you suggest us to look for before starting on basic treatment?
So, ma'am, most of the things have already been discussed, as you also rightly said. So, we have these many number of tests that can be done for diagnosing, but I feel that my experience is that since the disease is so paucibacillary, endometrial, and despite being very good tests like Gene Expert, TB culture is a gold standard test for diagnosing tuberculosis. But as far as genital TB is concerned, we don't get very good results at our lab also. Although we do get endometrial biopsies and all for TB culture as well as Gene Expert. But I feel that probably histopathology, seeing granulomas on histopathology or strong clinical suspicion is should guide for whether to go for ATT or not.
Dr. Jindal ma'am is there or ma'am is left? Dr. Jindal ma'am? I think ma'am was to go. So Dr. Natasha and Dr. Shalu can continue. Please tell me.
Ma'am, I will, in case I have a very strong suspicion and everything, then still I will take your opinion from an infectious disease specialist before starting ATT, because ATT can lead to hepatitis. So we cannot just randomly start, and we need to be very careful that when we are starting ATT, we should be giving the supportive medications to these patients, and we need to do the liver function test every month. And it's better to enroll an infectious disease specialist or a physician before we start ATP on the strong suspicion. Like Dr. Charu said, she had two things. She said, in case the granuloma, the tubules are showing granuloma, okay, that becomes a second point. Then we have two things which shows, yes, we should start ATT. But if the tubercles are not showing any granulomas, then how justified we are there to start the ATT? That is my another question which comes here.
Yeah, Dr. Shalu, now we are following the ICMR composite standard guidelines, and it's very rare to get granuloma positive on laparoscopy. Laparoscopy itself, if the findings are suggestive of tuberculosis, you are justified in an infertile patient putting the patient on ATT.
Yes, if the ESR we have done, it is raised, want to come positive, and other tests are directing in the direction of tuberculosis, and laparoscopy picture itself is so suggestive most of the time. and we start the patient on ATT. Sonia ma'am, please add something to
Agreed,
our
agreed,
knowledge.
Ma'am, Sonia
agreed.
ma'am, Dr.
I'm,
Rashmi
I'm
said
saying,
that we
yeah.
will be doing multiple tests. Can you give us like which test would you like to do in this patient?
You know, if it's this composite reference standard is basically a battery of tests which your own practice decides gives you the best results. Suppose in some endemic area you have your clinical sense is telling you the best, you know, your history is the best rather than any of them, then you will depend more on that rather than the investigation. That is what this is stating. It's not that, you know, if you see all the papers which are actually dealing with, you know, papers that have come out with the this composite reference standard being used, people are using different tests to make their own standards. This, it is basically, it just means that in your area, if you are very confident with your ultrasound and with your x-ray, and with that, even if there is only one ESR or something positive, you can still start the patient on ATT because your reference standard is that. But in case your reference standard is saying that your histopathology and the culture should be positive, then you have to depend on that. That is what it is. So there is a lot of variation in all the tests that have been done for achieving a composite reference standard. There is no
Ma'am,
set
this is the
test.
biggest confusion because patients are becoming smarter and smarter, coming out saying no test is positive. Why you are giving me such a
Well,
toxic drug?
no test positive will definitely not mean tuberculosis. You have to have something positive to say that she is tubercular. You can't say that she is tubercular even on the basis of suspicion. You have to have something positive on suspicion, you know. Only then you can say that this patient, but when you're saying that there is nothing positive, then you can't put the patient on ATT. Just because there is nothing positive, you can't put the patient on ATT. Unless you have something positive over there, then only you can put the patient on ATT. ऐसे नहीं कर सकते ना?
So basic take home message is something has to be like you
Yes,
should
of
have
course.
something in your hand to start the treatment.
Dr. Nisha.
Can I pitch in, Dr. Nisha?
Yes, Dr. Charu, please tell.
Ma'am, I want to add one thing. I was listening to all the lectures before this session. So, my opinion, I feel that tuberculin skin test, TST, Montauk's positivity should not lead to starting ATT directly.
Yeah, of course. Yes, we all know that.
That's not a good test to like diagnose tuberculosis. And plus, even IGRA. IGRA negative maybe can lead to like it can show us some light whether what to do next. But then IGRA positive doesn't mean that the patient has tuberculosis to be treated.
So what do you suggest? Which test should we do?
I beg to differ over here, Dr. Charu,
Yes,
because
ma'am.
now with this new elimination program, when we have the tuberculosis elimination program, IGRA is now suggested as a test which we can do. You know, you have to give importance to IGRA. If
Ma'am, that is for contact tracing, ma'am.
Exactly for contact tracing. But then again, if it is positive, it means that there is some antibody reaction going on in the body of the woman, isn't it? And here, where we are having a paucibacillary disease, where we don't have anything to tell us, if she has been exposed to it, and if she has an IGRA positive, चाहे contact हो चाहे directly हो, but then it shows that there is some activity.
I mean, there should be something supportive
Yes,
to
of course.
IGRA, ma'am.
Again, it comes in the composite reference standard.
Yes.
Again, you know, so it's not just that one IGRA will be positive, then it is tuberculosis. But along with that, if there is IGRA positive, you can't ignore it.
Yes, true. That is a supportive investigation.
Suppose, so for example, this patient of hydrosalpinx can be because of PID, non-specific pelvic inflammatory disease also. But if you have an IGRA positive, you will think of tuberculosis because IGRA be positive and she's got hydrosalpinx, so probably it's tubercular. You know, that is how you have to come to that conclusion.
Dr. Nisha.
Yes, so yes.
I just, before we conclude this case, I just want to simplify things. Like everybody said that go for DNC before doing endometrial sampling. How Sonia ma'am also said, But just I'm sharing my views. I can be grossly wrong also. We put in a laparoscope for all patients where we are suspecting tuberculosis, and patients do agree in spite of their low socioeconomic status also. And wherever we come across any fluid in POD, we just aspirate that fluid and send it for cytology. And now my pathologist is very well versed and he tells me that this picture resembles tuberculosis and this does not. So wherever the cytologist says positive, I go for all other my basic simple tests of ESR and everything, and we put that patient on ATT. And surprisingly, 7 out of 10 patients who are positive on cytology and receive ATT, they conceive. So it's a debatable topic and it's not a published.
Okay, not debate. No. See, Seema, this is your composite reference standard.
Yes, ma'am.
What stating is your composite standard, because basically you are basing your diagnosis and your treatment on the history and on laparoscopy and then on the other tests. So
Yes,
that is your standard. So therefore, that's what I was saying, that every area or every clinician, you will not be wrong, because basically they have given a battery of tests. Everything is listed over there. ये कर सकते हो, ये कर सकते हो, ये कर सकते हो. Now, in your particular practice, whatever is best suited for your patients, you make a standard for your practice, and that is what your composite standard becomes. So
Right.
it's variable. Now you are saying you're doing laparoscopy first. We are saying we are doing endometrial biopsy first. So there is a difference over there, but both of us are correct. Both of us are correct.
And the cytology fluid also, ma'am, it's very, very, very informative.
That is because your pathologist is used to it. Some pathologists will not even notice it.
Right.
So that is what I'm saying, that there's a difference over there also. Just as
So, ma'am, should we make a SOP for our clinic, or because isolated clinics, the main message we want to give individual practitioner is which test we should rely on.
Right.
So, in a hospital setup with multiple, practitioners, you can make your own SOP. But what about individual practitioners?
You should also make your own individual SOP.
Okay.
That is what it means. That is what this program is telling us, that this is the complete list of tests that you have to do. And if one of them is, you can decide which one is best in your hand. Is it radiology? Is it ultrasound, or is it histopathology? What is best in your hand, or laparoscopy? You make that as your standard and continue practicing that. That is what it means.
Can I pitch in a word?
Yeah, please.
Nisha, with
Rashmi
your
wants to
permission?
say something.
Hanji, please.
Yeah. So ICMR standard treatment workflow. It's a beautiful
Yes.
document which I showed in my slide. It divides the treatment part into three things. One is definite FGTB, wherein you find any microbiological evidence, whether AFP smear positive, culture positive, gene expert positive, or histopathology positive granuloma, you have to give ATT. These are definite.
Yes.
Number two, they have written is probable FGTB, which will rely on your experience, which says strong clinical suspicion plus either imaging positive or laparoscopy positive or hysteroscopy positive. You are justified in giving ATT as per the ICMR latest 2024 guidelines. So if there is a strong clinical suspicion, like in your case, she has a family history, she has a past history, she has a chest x-ray, some tubercles showing maybe she comes from an endemic area, plus there are tubercles. So whatever test may be negative, you may be right, and you can justify giving ATT as per the ICMR. Nobody can challenge in that case, because they have given such beautiful, guidance.
Beautifully. Yeah.
Okay. Now moving on to the fourth case, this patient has completed 6 months of ATT. Now, what are the success rates of IVF in post-TB? Because, her tubes are still blocked. She wants to go for IVF. So are the success rates affected after tuberculosis?
Yes, ma'am, they'll be affected, because I think in tuberculosis affected patients, there are 3 levels what we are looking at. The AMH is going to be low. We all know they have a low ovarian reserve. Then the endometrium, no matter if the basal
Will be affected.
There will be chronic inflammation, leaving back endometritis picture or maybe scarring there. And obviously, the tubes are the 100% cases which are affected. And if they are hydrosalpingeal fluid in that, the toxicity can, prevent the embryo for implantation. But in case all these factors are, I think, taken care of, the success rate can be around, I have not read the papers, to be frankly saying they should be good, because in today's era we have so many modalities of treatment, as Dr. Meenakshi Dua's lecture said. But yes, with all these features in hand, the success rates as compared to non TB patients are bound to be low.
Ma'am, I want to ask here is that because the low AMH we see, the poor quality oocytes we see, is it because of the poor malnutrition of these patients, which is the reason for tuberculosis, or tuberculosis itself is causing this?
Uveitis.
Dr. Leena, would you like
Yeah,
to?
it leads to uveitis. Inflammation of the ovaries is also
Tuberculosis
that
itself
also
is causing
affected.
uveitis also. So
Yes.
multiple factors are there: malnutrition, anemia, and then uveitis. So Dr. Vandana, are you there? Dr. Vandana? Okay, Dr. Shalu, can you take this? Should surgery be performed for these patients? And I think we know that Dr. Shalu?
No, the thing is that surgery should be only performed if we have something. Yeah, in case her hydrosalpinx is there. Otherwise, we don't need to perform a surgery for these patients.
Okay. So
Why
the
do
most
we?
important now is how long after completing TB treatment should we start, trying for transfer or something?
Normally, in these patients, we give this AKT4 and then followed by AKT2. That is it, the standard AKT4 for 2 months, and then goes the AKT2. So I prefer to give them AKT4 for 2 months, and then after that only I plan to go ahead with the treatment for them.
I think
And
Dr.
it
Leena,
depends.
you sent a message saying something, can you please elaborate on that?
Yeah, now
TB treatment.
TB treatment in intensive phase, it is given for 2 months, HRZD. We are giving all 4 drugs, INH, rifampicin, pyrazinamide, and ethambutol. And there's a change now that for the next 4 months, HRE is prescribed. That ethambutol has been added.
Added to it, yeah.
That's the change.
Okay. Do we need to confirm the absence of active disease? Again, do some EB or something? Is that
If we
recommended?
have persistent tumor masses, then in that case we do confirm. Or prior, if there was it was detected that endometrial tuberculosis was positive on histopathology, then in that case also we confirm by a repeat sample. Otherwise, not routinely.
Dr. Seema, can you take the fifth case, please? We are just about to end now.
Okay,
We'll be fast.
so this is in continuation of what we have discussed so far. She's 32 years old with multi-drug resistant genital tuberculosis and bilateral tubal occlusion, and now she desires fertility preservation. So how does MDR TB treatment duration or regime differ for genital tuberculosis? And I think I read all the questions and everybody can answer. What are the risks of ovarian damage from long-term second-line TB drugs? And what would be embryo or egg freezing be advisable before starting MDR TB therapy? Dr. Shalu, Dr. Nitasha, you can take this question.
I think, ma'am, intensive therapy is very important in these patients before we are attempting on any kind of ART treatment for these patients. And as far as multi-drug resistant TB treatment duration and regimen is concerned, I always take a help of a physician, and we do put these patients on some treatment. So I think this is from my side.
Dr. Charu, do you have anything to add?
Dr. Seema, I have a query. In MDR cases, we are not advising fertility preservation because there is already risk of flare-up. Handling such patients, they are already very sick, very high risk of mortality is also there. So I also would like to know from the other panelists, what is their approach, what are they following?
I think Dr.
Maybe
Nisha
we
will
can
add,
have
or Dr.
opinion from Sonia ma'am. Ma'am,
Sonia
please
ma'am.
opine. Sonia ma'am.
And Dr. Nisha, you also add to this.
I think we should prioritize the health of the mother here because she is multi-drug resistance. We do not know what is going to be her response to the drug, whether she will go on the higher thing or will she respond to it. As Dr. Leena said, touching her, we can flare, even if we touch the ovaries with the opio needle, we can always flare her tuberculosis to a further one upper limit.
Very,
But
very
at the
right.
same point of time, we
cause of
know that
indirect
this, at the same point of time, we know that this MDR therapy is also going to damage her. Like, it is decreasing her. There is a chance of uveitis. Her fertility is going to decrease. So I think the answer to this question lies in individualization. You have to assess that particular patient where she stands. If the risk outweighs the benefit, maybe you start the therapy, don't touch her. But if the benefit outweighs the risk, maybe you can go for, after proper counseling, you
Dr.
can do that.
Nita, the risk of maternal mortality is very high in MDR. It is very important indirect cause of maternal mortality. So we need to be very careful if we
Very,
are
very careful.
very,
Yes.
very careful.
Yes.
Dr. Meenakshi can add something to it. She comes out of the box. Dr. Meenakshi, are you there?
Yeah, I would like to share one of my case. I had handled one patient with MDR.
Okay.
Actually, I have two patients. Both of them have not conceived yet. One girl, she had a very good ovarian reserve. She was 35-year-old and her AMH was 4 or 5. We used to get 20-25 eggs and some 10 blasts used to form. But the aneuploidy rate was very high. Out of, I think, I had sent 6 or 7 embryos for testing, only one was normal. And next cycle, she didn't have much money, so we couldn't do PGT. We transferred 4 times in her. She did not conceive. Then in the last attempt, she even went to Gangaram and they advised all immunotherapy and everything. She took that. She conceived, but it was a blighted ovum. Then she came with a surrogate that I want the embryo to be transferred in a surrogate. We transferred her embryos in the surrogate. Surrogate also had a biochemical pregnancy. Biochemical pregnancy she had. So definitely it affects the oocyte quality. May not be the number of eggs. If the ovarian reserve was very good, then probably she will still have eggs, but the quality is definitely affected.
Thank you. Thank you,
Maybe
Dr.
she can
Meenakshi.
go for donor egg into her if
Yes, yes, that's what I had actually told her. You should take donor egg, but you can conceive. Because anyway, it implanted in her.
You have to discuss. It is advisable, but the counseling has to be best. All and multidisciplinary approach has to be there. So
Right.
now this is the last case, post TB pregnancy risk. What are the pregnancy complications? She has completed everything. She has she's pregnant now. So what pregnancy complications are you expecting? I think ectopic rates are also very high. Dr. Shalu, can you address this? How should her antenatal care be modified to monitor for adverse outcomes?
So in these patients, because of the tubal involvement, the chances of ectopic pregnancy and the miscarriages are very high. Abnormal placentation site, because that is also there. Cervical incompetence and difficulty in during cesarean because of the presence of adhesion is there. So when the patient who had a tuberculosis become pregnant, we need to make sure that we check on the doubling and do an early scan for her to make sure that the pregnancy is inside the uterine cavity, not the ectopic. This patient should be, we should already explain them that, as Meenakshi said, that the patient had pregnancy and embryonic pregnancies. So we need the patient to understand that these are the factors which are there. And because of the poor endometrium and the infection which was there, which has sometimes damages at the molecule level, the endometrium, the chances of placental insufficiency is there, which can lead to IUGR. So these patients basically needs to be little more monitored. We need to be doing the repeated ultrasounds to make sure that placental insufficiency and the growth retardation is not there. Once I think they cross 28 weeks. So we are more comfortable looking in other things that, okay, no cervical incompetence, no IUGR, no placental insufficiency, they will do PEP. And during the cesarean, we should be aware that when we are going for a cesarean, that we may land up into difficulty when doing a cesarean. So we should be mentally prepared and have all the people there for us help in case we land up in any kind of difficulty during the cesarean section.
Okay, so I think Dr. Shalu has, anybody wants to add anything to that? Dr. Natasha, Dr. Leena?
And the chances of transmission via the placenta are very high to the baby. So I don't know whether I have seen in my government medical college days, chorionitis in these patients are very high. The risk of prom and preterm delivery is also high, and the babies are also very IUGR, FGRs actually. So probably they would, and most of these are neglected. We wouldn't even know unless until we have delivered them and we see the placenta with calcific spots, deposits that they are having active TB or whatever TB. So I think there is no screening guidelines for tuberculosis in patients who are already conceived and walking to you. This is
I
it
think
from
after a whole 2-hour discussion also, there is still that question in my mind, which test to do, how to diagnose, what to do. There are so many, we need to still work on diagnosing first, identifying, and then treating them well. That's the end of our panel. And thank you so much. I think we got some take-home messages at least. Early scan, 3D scan, some kind of confirmation before starting. Then Dr. Sonia ma'am's message about developing your own SOPs, having that risk, having that open mind, and identifying it. That these are all the key points.
Ma'am, probably if the ICMR guidelines are, as Dr. Rashmi also rightly said, if we follow the ICMR guidelines, probably things will be a bit sorted.
True.
Yes.
True. I think ICMR has really made the task very easy because it has.
It could be microbiology. It could be. Yeah, it could be diagnostically proven tuberculosis and it could be clinically suspected tuberculosis. So both the ways, like if there is a strong clinical suspicion, I think take the sample, endometrial biopsy, send it for all the tests, including histopathology, including all the microbial like CB/NAT, TB culture, everything, and then in case everything turns out to be negative and you have a very strong clinical suspicion, then that case goes into clinical tuberculosis case as per the ICMR guidelines. So probably
but what about menstrual blood? Most of us have a tendency to sending menstrual blood and then diagnosing.
It's not a good sample, ma'am. Menstrual blood.
Only for unmarried, if we have
although in my past 15 years of experience, I have seen one menstrual blood sample turning out to be positive for MTB in TB culture, but I will not suggest menstrual blood as a sample.
Okay, with this, we conclude our first webinar. I want to thank all my, first of all, I want to thank IFS President Dr. Neena ma'am and Dr. Shweta ma'am for giving us this opportunity. I want to thank our mentor, Dr. Sudha Prasad ma'am, under guidance of whom we have, started this. Dr. Rashmi is really working very hard to, by the end of 2 years, we should have some guidelines at least that how to work around TB. Dr. Leena always there to guide us. Our experts, Dr. Sonia ma'am, Dr. Gauri ma'am, Dr. Sudha ma'am, and Dr. Umesh Jindal ma'am, thank you so much. And we have released our first newsletter. It will be available. It will be circulated. Thanks to Dr. Leena ma'am for guiding us. And I thank all my panelists. And I thank Dr. Sonia ma'am, especially for her comments. Thank you so much for this interactive webinar and interactive session. Thank you so much.
Thank you, everyone. Thank you, all the panelists and the moderators. Thank you so much. Thank you so much. And
thank you, Dr. Nisha, for conducting all the program from Bali. Yeah.
Congratulations. Very well done. And I think next time we can have something related to pregnancy, patient having tuberculosis or with having MDR tuberculosis.
Yes, we should.
Yes.
We should. Thank you. Thank you, Dr. Leena. Thank you, Dr. Rashmi. Lots of support from your side.
Thank you.
Bye-bye.
Thank you, Dr. Jyoti, specifically to you. You managed it so well and arranged everything on time. Thank you. Thank you, Dr. Priyanka, Dr. Charu, Dr. Murugan. Thank you, everyone. Dr. Natasha. Thank you.